All right, looks like we're live. Hello, everyone. So today I'm joined here with Dr. Avi, and we're going to be debunking Dr. Dean Ornish, Dr. Caldwell Esselstyn, and Dr. Michael Greger's atherosclerotic coronary artery disease claims. They claim that with a low-fat, whole-food, plant-based diet, you can reverse atherosclerotic coronary artery disease. And right now, it just doesn't look like the data supports these claims. With the data available, you just cannot, in good faith, make any of these claims. So Dr. Avi is just going to go through all of the relevant science to debunk these claims that these doctors are making.
All right, so a couple of things. So some people have asked a lot of questions. People have asked what my motivation for doing this is. Couple of things out of the way. This isn't to trash anyone's work. This isn't to trash anyone in particular. It's to discover the truth, for the truth to be shown. Ultimately, I want our movement to be founded on truth, and I don't believe false claims for the sake of improving public health or saving animals is going to be ideal toward achieving those ends. The claim that any dietary intervention can reverse atherosclerotic coronary artery disease is just an unsubstantiated claim. This isn't to say that case for reversal hasn't been proven. It's actually worse than that. It's to say that not only has it not been proven, it hasn't even been shown to be more probable than not. There's no evidence that gives us reason to believe that reversal of atherosclerotic coronary artery disease is even probable based on any lifestyle intervention. So what do I mean specifically and what do I not mean? So what I'm talking about, I want to be very clear because people can misinterpret this and people can take this out of context. I am talking specifically about, which is claimed, by the way, reversal of atherosclerotic coronary artery disease, reversal of the plaque buildup in the coronary arteries. It could very well be that a lifestyle or dietary intervention can reverse some other form of heart disease. Now, I think those claims are sketchy as well, and we can go through those. And it could be some of them pan out. But the only thing I would caution when evaluating those things, those types of heart disease reversal that are tangential to atherosclerotic coronary artery disease reversal, I would caution you to be aware of what else you'd have to bite the bullet on calling a reversal of heart disease. So, for example, if you want to try to make one of these moves and say, oh, well, I get that you can't reverse plaque, but you can reverse ischemic heart disease because you can dilate the artery. Okay, fine, but are you going to bite the bullet on like arginine if it showed the same dilation because of the nitrates? Are you going to bite the bullet on vasodilator medications? You're going to say that these medications can market themselves as heart disease reversal agents because they can reduce some amount of ischemia because they dilated the vessel. So be aware of those kind of things. Wherever you set your bar, be careful of biting the bullet on all sorts of hilarious things. Regardless, for now, we are going to talk about a very specific claim, the reversal of atherosclerotic coronary artery disease. The claim has been made, and it hasn't been shown. So we're going to go through certain forms of terminology. I'll share my screen for now. Okay. I'll go to screen share. So it's important to understand what we're talking about here because there are a lot of acronyms, and I'm going to go through them now. So you can always refer back to this if you don't understand what's being said. If I say ASCVD, I'm talking about atherosclerotic cardiovascular disease. If I say EASCVD, I'm talking about epicardial atherosclerotic cardiovascular disease. If I say MPI, I'm talking about myocardial perfusion imaging. If I say IVUS, I'm talking about intravascular ultrasound. If I say QCA, I'm talking about quantitative coronary angiography. If I say MLD, I'm talking about minimal luminal diameter. Let's go over the terminology for quantitative coronary angiography. What do I mean by minimal luminal diameter? What do I mean by the reference diameter and percent stenosis? Hopefully you can all see this. It's actually fairly small. I don't know if you could blow it up on your stream, Richard.
It's a little low resolution.
Mm-hmm.
That's the issue.
Gotcha. Okay.
So
as long as you can blow it up so the audience
out.
can see it.
I think they can kind of make it out. Let me.
Yeah.
I don't know if I can just. No, I can't zoom in. And wait, can I open original? Oh no, wait. Yeah, I'm sharing it. Let me just try to zoom in. All right. think people can kind of make it out.
Yeah. So you have an artery, you have a plaque buildup, as you can see.
So the two lines just represent the artery.
Yeah, the artery wall.
Right. Okay.
And the minimum luminal diameter is the smallest diameter of the artery.
So
and you can see it's, in this case,
yes. So the two red things, that's plaque buildup.
Correct.
Okay.
And where you see B, that's the reference diameter.
Okay.
So of the disease-free segment of the artery. And when we say percent stenosis, what we're talking about is just a ratio of A by B. So A divided by B. So percent stenosis is just your minimal luminal diameter divided by your reference diameter. Okay?
Okay, sure. Yeah, that makes perfect sense to me.
Okay, so this is just getting some terminology out of the way. We're going, since the debate with Mike the Vegan, Dr. Gregor has responded to the debate. I'm going to respond, before I get into this, to his video, or his interview that he did. So if you can, I think you can pull it up on your stream. It should start at 15:30. I don't think I'll be able to hear it,
Sure.
but just play the entire segment.
Sure, I can do that.
This is very
let me know.
recent.
Yeah, let me know when it's
on
done.
Saturday, I know Dr. Ornish, Dr. Kim Williams, Dr. Danielle Belardo, they're going to have this sort of conversation around heart disease and if it's truly reversible. And so kind of where the argument stems is that when we look at like Dr. Ornish's research, there's a 3% regression, and that's apparently not clinically relevant, or in the scientific literature for actual regression, you need a was it a 10% change in percent stenosis? Like, what would you say about these sorts of, I mean, ultimately, I think the event reduction, the reduction in heart disease risk that we get with a plant-based diet is more than enough. But as far as the nitty-gritty of whether we can truly claim reversal, what would you say to that?
Of course we can claim reversal. So what they're doing is they're trying to use some statin definition that was used, for example, in the asteroid trial. But that's just talking about stenosis. I mean, look at Ornish's PET scan data, like a 300% increase in blood flow to the heart muscle itself. That's what we care about compared to the control group, right? I mean, we have to think about the collateral arteries, the improvement in function. We are reversing the progression of heart disease, not just symptom-wise, but literally in terms of how much oxygen is getting to the heart muscle. That's what we care about. And then this then translates into reduction of events. What else do we have to need? Why people are bringing up this ridiculous kind of semantic, silly arguments makes no sense to me. And I think Dr. Ornish is going to school some folks.
Okay, you should join him. I'd love to see it.
Okay, so I think that was the entire clip.
All right, cool. So a couple of things with that. So number one, this wasn't actually the paper from 1990. This was actually the Ornish paper from 1998. So that's just a false statement. Number two, I haven't ignored any of the evidence that came after that, the myocardial perfusion imaging. That's just evidence that didn't come up in the debate. I'm very much aware of it, and I'll be responding to that evidence in this video. Next point is some statin definition. There are multiple definitions in the literature for what constitutes a clinically relevant reversal or regression of disease. I was using the lowest one that I found, the 10%, or in this case, the 10% in conjunction with 0.2 minimum luminal diameter. Some go higher than that. Some definitions go 20%. Some definitions go 0.4 change in minimum luminal diameter.
So you're being extremely generous with your definition as well.
I was being generous to it. And the reason why I suspect they were trying to get that down is that in the asteroid trial, the lower they get that bar down, the more likely it is for their statin to be able to make the claim. They were trying to get that down.
Okay.
I was trying to be generous. And yeah, how dare I use the definitions in the literature using
so the definition you were even going by, it was kind of slanted towards supporting these sorts of drugs, so it might not even produce clinically relevant changes.
Exactly. But regardless, there's a whole bunch of larger problems. The other thing I will say is that I did, and again, like if you're watching this, Dr. Greg, I'm more than happy to have a conversation with you about this. If you're willing to opine on interviews about the things that I've said, then let's have a conversation. I know you have turned down the debate offer, but if you're down for a discussion on the topic, I'm happy to have one. But in any case, I will be going over all of those things. I will be going over the myocardial perfusion imaging. I will be going over the quantitative coronary angiography. I will be going over the outcomes. I will be going over our formal argument in regards to this specific claim. And one more thing I noticed, if you may have noticed this move. This is a super sort of sophist move, actually. That they'll say, okay, that's just the stenosis or that's just the plaque. But what about the blood flow? Doesn't the blood flow at the end of the day, no matter how you get the blood flow, if you show improvement in myocardial perfusion imaging, isn't that what's mattering at the end of the day? Isn't that the only thing we care about? What does it matter if you haven't reversed your plaque? If at the end of the day, whether it's through dilation or collateral formation, what does it matter if at the end of the day you're getting your blood flow? So this is an extremely weaselly move if we're criticizing the claim of reversal of atherosclerotic coronary artery disease. Because yes, it could be true that you've shown what matters with respect to what we care about with respect to a given goal, but that thing that matters hasn't been shown to be reversal of atherosclerotic coronary artery disease, which was the point of contention in the first place. The point of contention wasn't that you haven't shown the thing that matters. The point of contention was that you haven't shown atherosclerotic coronary artery disease reversal. That was the point of contention. So to say that, hey, we've shown atherosclerotic coronary artery disease reversal because we can show improvement in myocardial perfusion imaging, and then when I say, hey, wait a minute, myocardial perfusion imaging underdetermines atherosclerotic coronary artery disease reversal because you can have it through 1.5 million different reasons that have nothing to do with change in plaque. If you then try to say, but what does it matter? At the end of the day, the only thing that matters is the blood flow. Are you getting the blood flow to your heart or not? That is a weasel move.
Yeah, totally.
You cannot, that response does not go through. Yes, because you're changing the topic. You can show what matters, but that was never in contention to begin with. The point of contention wasn't if you're showing what matters. The point of contention is, are you showing reversal of atherosclerotic coronary artery disease? Okay? Be very aware of that type of sophist move. All right? Let's go through the alleged evidence. Okay. So, alleged evidence is as follows. Number one, quantitative coronary angiography. So as Ornish did a randomized controlled trial with this, Esselstyn did a non-randomized trial with this. And the idea is that shows improvement in stenosis and or improvement in minimal luminal diameter with the plant-based diet. The second alleged evidence is myocardial perfusion imaging. The idea is that they've shown improved blood flow with their intervention. Third line of evidence is through outcomes, less likely to die from coronary artery disease, CVD deaths, maybe all-cause mortality, CVD events. The next line is symptoms. People who are put on this intervention are less likely to have heart disease symptoms. Ejection fraction is also one of them. Those placed on the lifestyle intervention can show improvements in ejection fraction. And then finally, there's anecdotes. So stories, testimonials, cherry-picked angiograms. These lines of evidence don't end up showing what they're purported to show. Here's just an example of, this is actually from the Esselstyn paper. Can you see this on my screen, Richard?
Yep, very clearly.
Okay. Yeah, so in figure 1, you see that there's restoration of myocardial perfusion. Figure 2, this is the classical cherry-picked angiogram. And so, yes, there's improved blood flow. If you look just at the bottom, here's one of the many reasons we should be suspicious that this is coming from regression of atherosclerotic coronary artery disease. This happened in 3 weeks, this figure 1.
Yeah, that's insane. There's like no possibility that could happen.
This is not a plaque regression. Your plaque does
Yeah.
not regress and give you this. I don't care if it's to the power of 4, of r radius to the power of 4. Doesn't matter. You're not going to get this type of improvement, even if flow is proportional to the radius to the power of 4 in 3 weeks. It's just insane. There are many other factors that you can get that. There's dilation, there's collateral formation. Fine. But this is not because of a plaque regression. So it seems already to be very clear that right off the bat that there are other things going on here that underdetermine change in plaque. And as far as the 32-month in figure 2, that's fine. There are plenty of anecdotes, but we don't determine that any given intervention produces a given outcome through anecdotes.
Yeah.
We just don't. We need some sort of data. We need some sort of analysis. Let's go through all the data. Okay. The first line of evidence is quantitative coronary angiography. These slides are given to me with permission by the great Charles Michael Gibson, who is an interventional cardiologist at Harvard, who has also pioneered techniques in quantitative coronary angiography. So the idea is you inject the dye into the coronary arteries, and the artery will cast a shadow on the X-ray film. Dark edges are the edges of the artery, and the opacity, the radiolucent area, is the blood flow. So what it is a luminogram. You're looking at blood flow in 3-dimensional space. There is no cut point that is sharply demarcated to tell you whether you're talking about a lumen or an artery wall. You can approximate it, or you can have a computer try to draw it in, as you can see over here. But it's never a precise science, which is fine. It's not a problem that it's not a precise science. There's just going to be a lot of internal variability. So what I will show you is, take this, for example. What is your impression, if I were to ask you, Richard, if you were to look at these 3 angiograms, right? What do you think it looks like what's happening to the stenosis of this artery?
Well, it looks like it's opening up.
Yeah, it looks like it's opening up, right?
Yeah, that one looks narrower.
You might even
than
call
one in the
this...
middle.
Yeah. Yeah. And so the question is, how long do you think it took for this lesion to regress? And the joke here is that it actually took a few seconds, because this is actually the same angiogram. It's just a different frame in the same angiogram. There's frame-to-frame variability in these angiograms. So always keep in mind when someone shows you this, like, oh, look, this angiogram, there are so many things that can show you a change. And you can swear, you can think, like, I am so sure this is a plaque. And you can look at it, and there's really no case to be made that this is a plaque.
Right. So just
doesn't mean that's always the case, but yeah.
So just because of the variability in these angiograms, you really need to have, you really need to show a lot of angiograms between a lot of different people to really determine whether or not there's an improvement.
Yeah, and now you could try to make that case. You can say, okay, I understand there's a whole lot of variability. I understand there's internal variability. I understand there's variability from frame to frame. There can be variability within the same frame. If you're gonna, there's a whole bunch of different issues that cause variability. But you can make the argument to say, okay, but that's all going to be washed out through the randomization process anyway. If I wash it out and I say, okay, like I'm going to randomize, so there's going to be variability on both sides of the equation. There's going to be variability on this side of the equation in the control group. There's going to be variability on the side in the treatment group. So at the end of the day, if I'm finding something statistically significant, maybe I'm showing what I'm trying to show, even though there's a whole bunch of variability. And the answer to that is no. You're still, even if you do that, you're still not showing what you're trying to show. And there are several reasons why. And those reasons are called pseudo-regression reasons. For one of many reasons. But let's go through this example. So, do you see, Richard, do you see this artery I'm showing you over here? And where you see that you have this area of like normal artery, and then you have the stenotic segment over here, pre-intervention?
So the normal artery is where the arrow is.
Mm-hmm.
Okay.
Yeah, that's normal segments. You can see it's like nice and wide, it's opened up. And then you see the artery segment over here that's all narrow. That's the stenotic segment.
Sure.
And now you see the same artery You see that this artery, the stenotic segment, is still the stenosed as usual.
Right, and
but
that's
then you see
post-intervention.
Post-intervention, the normal artery is now stenosed.
Right.
Now, if you think about this, what is this going to do to your percent stenosis?
It's going to show improvement to percent stenosis because
Exactly.
the reference portion of the artery is narrower.
Yeah. So minimum luminal diameter divided by reference artery will show you an improvement in percent stenosis. You can read this in quantitative coronary angiography, and it can look like regression when it's actually progression. It's actually getting worse. Another phenomena is when there is a buildup of plaque. What can happen is the vessel can become ectatic right at that portion of the stenosis. Up to 40-50% stenosis, that compensatory mechanism happens. And so the idea is that just because there's an artery doesn't mean it has to constrict or dilate in unison. There could be focal points where there's dilation and focal points where there's contraction independent of each other. And that does happen, and it's been documented. The idea is that for example, if you have your baseline quantitative coronary angiography you have your stenotic segment, you have your normal reference artery, it's on a dilated day, and then you have the follow-up on a non-dilated day of the reference artery. Relative to the reference artery, there's still going to be dilation of the stenotic segment because of that compensatory mechanism. And so that's another way you can have a decrease in your reference artery while relative to that reference artery improving your stenotic minimum luminal diameter. So there are many things that can happen in between these two snapshot points that actually don't track with plaque volume. Now, what you can say is that, okay, you can cherry pick those cases, but wouldn't it be intuitive that overall these metrics can track with plaque volume? So even if you want to say that, all right, so there are some problems, there's variability, that even within the same angiogram, depending on the angle you look at it, depending on a whole bunch of different factors, depending on where you are in the cardiac cycle, if you're in systole or in diastole, all of that stuff. Even if we acknowledge there could be pseudoregression, isn't there some correlation? Isn't there some reason for us to believe that there's an improvement in plaque if we actually show a change in the right direction in quantitative coronary angiography? Now we have that answer. There is data for that answer, but I should point out that even before we had this answer, there was a paper published called Limitations of Angiography for Analyzing Coronary Atherosclerosis Progression or Regression. And they pointed out all these conceptual limitations, and they said it's not a useful tool to analyze regression or progression. In fact, if you can pull up that paper on your stream and just look at the conclusion. And this was back in actually back in 1990.
Oh, wait, we're just going to screen share? Okay.
Oh, yeah, and maybe I could just hold on. Probably
because you'd have to send me the link.
Oh, yeah. Actually, no, it's fine. This is actually. Oh, yeah, I can do it. I'll screen share it with this. 1 second. So I'll screen share. I have to change it to screen share this thing as well. Or limitations of quantitative coronary angiography. Okay. So this was published in 1994, right? And so even before we had this data, sclerosis progression or regression.
So
now,
by the time
go ahead.
So by the time like Ornish and Esselstyn published their papers, they ought to have known of this.
All right. So that's not what I'm saying. I'm not going to go that far because first of all, Ornish published his paper in 1990. So no, I don't think that would be a fair criticism. He published a follow-up paper in 1998, but that doesn't mean he necessarily read and had to agree with that paper.
Sure. Okay.
And to be fair, I don't actually, if that's all we had, I don't actually necessarily agree with that paper either, in saying it's completely useless, because my intuition would have also told me, to be fair, that there probably would have been some sort of correlation. That if changes in quantitative coronary angiography metrics, even if they have these problems, maybe they're still probably giving you some sort of reason to believe there's improvement rather than worsening of the plaque. And of plaque volume, I should say. And later they found out that the answer to that was, no, actually not. Not unless you use high cut points in categorical data, like 0.4 millimeters change in minimum luminal diameter. As a continuous variable, there's actually no correlation at all. And so I'll screen share and we'll go through that data as well.
So basically, they might have. So the data that they had to work with by the time they published their papers, it would suggest that this sort of angiography they were using probably could show a correlation between stenosis and atherosclerotic coronary artery disease. But since then, it's basically just being debunked.
Yeah, it really would just be an intuition pump, honestly. And to be fair, I would have that intuition pump. Even if I read that paper, I would probably have that exact intuition pump. I would probably say, you know what? I think you're being overly harsh. I think okay, fine. It turns out they were completely right. So fair enough to them. Now I'll share the data that really just puts the nail in the coffin. And that's comparison of intravascular ultrasound and quantitative coronary angiography. So here's what they did. So what ended up happening is there was a trial on a CAD inhibitor, a 2-year trial. And what they did is at baseline, they did quantitative coronary angiography and they did IVUS. IVUS is intravascular ultrasound. And that's a modality that actually measures plaque volume. So you can take ultrasound in the artery and you could measure. You have a great spatial resolution to measure the plaque volume that you just don't have with many other imaging modalities. So that gets us what we're actually looking for. How much plaque is actually there? So they did both of those things at baseline, and they did both of those things at 2-year follow-up. So quantitative coronary angiography and IVUS at baseline, quantitative coronary angiography and IVUS at follow-up. And what they found was that, now you have to be very careful with this study, it's very easily to misrepresent, and many people have misrepresented it, because if you just look at the background, if you just look at the abstract here, and you look at the conclusions, you'll get the impression that this correlates. And it absolutely does not, right? So if you read the conclusion, it says, quantitative coronary angiography and IVUS-derived measures of lumen dimensions are correlated at single time points and for changes over time. Hey, looks like we're correlating. Although the change in percent atheroma is only weakly correlated with quantitative coronary angiography changes as continuous variables, disease progression on quantitative coronary angiography is associated with significant increases in plaque volume on IVUS compared to no angiographic progression. Now, reading that alone, you'll probably get the idea that, hey, maybe there's a weak correlation at some things, but that gives us a reason to believe that it's going in the direction we're telling you. And the answer is no. And this is that is just a function of not actually reading the paper. And there's plenty of people who have done this and have come to me and be like, hey, Avi, look at this. How can you say this? It's saying there's a correlation. Like, no, you're not reading the paper. What they defined, first of all, before we even get there, change in percent atheroma volume is not what we're talking about. Change in percent atheroma volume is not change in absolute plaque volume. A change in percent atheroma volume can actually improve when when absolute plaque volume worsens, if your artery just dilates. So imagine that you have a certain amount of plaque and it gets worse, meaning there's more plaque now, but because your artery dilated to a greater degree than your plaque increased in volume, you can actually have an improvement in your percent atheroma volume while you have a progression of plaque. No one would consider that reversal. Are you following what I'm?
Yeah, I'm totally understanding.
Yeah.
I
So
think most
there's a
people
big
listening
difference.
would be able to understand.
Okay, awesome. So there's a big difference between percent atheroma volume, which is not what we're trying to track, and absolute plaque volume. But then
just
it
how
also
much plaque
says that
is
it's
actually in the artery.
yeah. But then it also says that there is some relationship between that and plaque volume, but you have to understand where that's coming from. What they defined progressors and or regressors to be is based on a change in minimal luminal diameter of 0.4 millimeter. Okay, so they're using categorical data. They're splitting people out. They're saying, okay, if you had a change in 0.4 millimeters in your minimal luminal diameter, whether for the better or for the worse, or greater, you will be classified as either a progressor or regressor. If you improve by 0.4 millimeters, you're a regressor. If you got worse by 0.4 millimeters, you're a regressor. If you did neither of those things, you're neither a progressor nor a regressor. Okay? Now, when you do that, there is a relationship with some of the plaque. So if you look at table 9, yes, there's a relationship between baseline plaque volumes of 146 millimeters cubed and 190 millimeters cubed for the point estimates. For larger plaques, there was not. But yes, there can be some. However, the point here is that that's only been shown if you have hot cut points that are that high, which no dietary or lifestyle intervention trial ever kissed the toes of. None of the trials involving dietary interventions or lifestyle interventions ever even got close to a change of 0.4 millimeters minimal luminal diameter. And as a continuous variable, if you just instead of using categorical data, if you just look at it as a continuous variable, you would expect there to be a correlation, but there isn't. If you look at the correlation between what we're looking for, which is the change in absolute plaque volume, between quantitative coronary angiography metrics, such as change in coronary artery score, so that's the summation of the average minimal luminal diameter changes, or the change in cumulative coronary stenosis score, that's the average summation of the percent stenoses. Those changes not only do not correlate with plaque volume changes, it's not just that it's not a statistically significant correlation. The point estimates are just sitting right next to 0 for the R values.
Right.
Okay. So this isn't an issue of the people not progressing enough or regressing enough. There wasn't enough change to track. It's not an issue of the sample size. It's not a power issue. It's just the point estimate is just sitting right at the 0. Like if you see a correlation with R is equal to 0.1, that's very weak. This is like these numbers of 0.02, negative 0.002, negative 0.
It's like nothing.
It's nothing. It gives you no more reason to believe that there's a progression of plaque rather than a regression of the plaque.
Right.
So this paper just completely puts the whole thing to bed. There are some potential sophist moves that I do want to get out of the way. So let's get those out of the way. Let me put the appropriate screen share on. One potential sophist move is to say that in the actual trial, with the trial that this correlation has been done with, maybe it was because there was not enough change in the study arms. So what this trial did was they had different arms. They had a placebo group, they had a drug, which was an ACAD inhibitor, 50 milligrams, 250, 750, and then they just had the all summation. And they had a baseline and they had a 2-year follow-up. Now, if you look at the change in plaque volume, you can see that there was no statistically significant change in plaque volume in any group compared to any other group. Okay? So what someone might say is that, well, the reason you haven't shown that quantitative coronary angiography is correlating with changes in plaque volume is because there was just no statistically significant change in plaque volume between the groups in this trial in the first place. Now so before I go over the refutation to that, do you understand what that argument might be? What I'm trying to say?
So they're basically saying that between the groups, so because there was no between group difference, obviously you're not going to see a difference with in group difference. You're not
going to see any difference and you're not going to see any correlation in changes in QCA and changes in plaque volume because plaque volume is not changing.
Right.
How can you see a change in plaque volume if plaque volume isn't changing?
Right. Okay.
Okay. And so the shutdown to this is plaque volume absolutely is changing. The fact that there is no difference on average between the different groups doesn't mean that there aren't a lot of people who have progressed and regressed. In fact, if you just look at the standard deviations at baseline and end of study, they're quite substantial. If you look at the mean change and the standard deviations on that mean change, 26, 30, 24, 33, overall 29.5 millimeters cubed. That's enough that you would pick that up on IVUS. So it's not that plaque isn't changing in any of the participants. Plaque absolutely is changing in the participants, and you should be able to see that change. All that it is happening is that the plaque is not changing relative to the different groups, but that's irrelevant because the correlation was done on a per patient basis. So
Okay,
you would still be able to track the correlation if the correlation is there. Not saying anyone has made that potential argument, but this is something to keep in mind of what people actually. Someone has made this argument. I'm not going to say who it was, but it's come up, and that's the shutdown to that. The other thing I'll just point out, if you look at this table, which, by the way, Dr. Greger, if you're watching, is not from the 1990 paper. It's from the 1998 paper. But anyway, if you look at, this is the Ornish trial at baseline 1 year and 5 years. If you look at the minimum luminal diameter, the minimum luminal diameter didn't change at all. It didn't budge. And the reference diameter actually almost statistically significantly decreased. If you look at the normal diameter in the experimental group, it actually declined. And so maybe that's something, maybe that's not something, maybe that's a progression of plaque in the reference artery, maybe it's not. If you look at the control group, by the way, that worsened, they actually, to a small degree, had an improvement. If you look at the confidence interval, it's actually a statistically significant improvement in their normal diameter, which is partially where that worsening of the percent stenosis is coming from. Because again, remember, if you are decreasing the diameter of your reference artery, you can improve your percent stenosis artificially.
Sure.
The opposite is also true. If you increase the diameter of your reference artery, you can worsen your percent stenosis artificially. If your reference artery just dilates and the stenotic segment of the artery doesn't, maybe it's at the 40-50% and the compensatory mechanism has failed. I don't know. Or maybe it's failed for some other reason. In any case, I don't think it's that meaningful, but take it for whatever you will. So one might say, okay. Before we go further, the Esselstyn study, that wasn't a randomized controlled trial, but they did not show, they showed a 7% improvement in percent stenosis, and they did not show any statistically significant improvements in minimum luminal diameter. It was 0.1 or 0.08, depending on how you're rounding it. Not statistically significant. Now, here's what someone would say, okay, but now you're just focusing on the stenosis. What about the myocardial perfusion? Can't we say that look, it's radius to the power of 4. So if we just open it up, radius to the power of 4, then even a small change can improve the myocardial perfusion. So if we look at that, first of all, as I've said before, there's reason for us to believe that even though you can show improved perfusion, that this is not coming from a change in plaque, as opposed to things like dilation or collateral art formation. There are examples of this happening in very short amounts of time. Plaques take a long time to regress. And then there are whole sorts of other things that can cause a improvement in myocardial perfusion that are not regression of plaque. In fact, one of the papers Dr. Ornish published was on pomegranate juice improving myocardial perfusion and myocardial perfusion imaging. I'll just show that paper really quickly. Okay, just screen share this.
Yeah, so if pomegranate juice can improve myocardial perfusion, it's retarded to say, like, Do
you think pomegranate juice reverses heart disease?
Yeah, it's just ridiculous. You can't say just because there's an improvement in myocardial perfusion that it's evidence that you're reversing heart disease. Or you'd have to bite the bullet and say, great, pomegranate juice reverses heart disease.
Right. Now, you can have a definition. You can say, like, okay, well, technically, there's ischemic heart disease. And if you want to get really technical about it, well, maybe you're reversing the ischemic heart disease because you are dilating the vessel or whatever. Fine. But now you look at everything you have to bite the bullet on. You have to bite the bullet on vasodilator medications reversing heart disease. You need to bite the bullet on pomegranate juice reversing heart disease. You need to bite the bullet on, I don't know, maybe even arginine supplements, assuming they did reverse it to this degree of improved blood flow. But no one reasonable would say that. So you have to be very careful about what you're going to bite the bullet on if you're going to try these proprietary definitions, or even if they're not proprietary definitions. Wherever you're setting the bar, you have to be very careful with that.
Yeah,
but regarding
that can dangerously mislead people. If you're going to say you're reversing heart disease, then that could incentivize them to go off of like medications. And I mean, it's ridiculous to say, oh, pomegranate juice will reverse your heart disease, and then that'll incentivize somebody to get off of their prescribed medications. So it's really stupid to go by that sort of standard.
Yeah, and the same thing would be true with any diet. Fact, especially for secondary prevention, the fact that you have improved symptoms, you've reduced your risk, does not mean you have the ability. It does not mean it's advisable to go off your guideline-directed medical therapy. All right, so there's that. So the point here is that myocardial perfusion imaging underdetermines change in atheroma. It underdetermines change in plaque. Okay, and now we'll continue. Let me go back to Discord. Okay. Same thing is true with outcomes. Outcomes and symptoms underdetermine change in plaque. Anecdotes don't give us reason to infer change in plaque or that any change is due to dietary intervention. When you make an apples-to-apples comparison, I've done a video on this. I know Dr. Esselstyn has tried to compare his study to the Lyon Diet Heart study. I have a full comprehensive debunk of that on my channel. We could put a link to that. Essentially, it's not an apples-to-apples comparison. He did a subgroup of a subgroup and compared that to just a regular experimental group. So he took his experimental group, did a subgroup of a subgroup, and then compared that to the experimental group of Mediterranean diet. And when you actually do an apples-to-apples comparison, the events are actually very similar.
Right.
But that's besides the point. Yeah, go ahead.
Well, just to briefly summarize, he was only tracking deaths that he assumed were recurrent disease, whereas in the Lyon heart study, they didn't. They just looked at all deaths.
Yeah. They also looked at events that the Esselstyn study just didn't even report on.
Yeah,
hospitalizations for stable angina, and the major difference came from elective revascularization. It's decisions that you make, not something that organically happens to the patient anyway. Okay, so we can go through the formal argument because I do have a formal argument. And before I do that, let's just go, because I know there's going to be someone who's going to try to make the case that actually, this isn't what Dr. Ornish and Dr. Esselstyn are talking about. They're not talking about atherosclerotic reversal. They're talking about something else, one of these other things like ischemic heart disease reversal, and they'll bite the bullet on some kind of pomegranate juice or something as a reversal agent. So I just want to make it very clear that claim was made, All right, and so I'm gonna show it to the audience that this, just so there's no ambiguity of what claim that's made, so no one can say I'm unfairly strawmanning or criticizing someone. So I'm gonna screen share that. All right. Okay. So notice how it says reversal. It's in the title of the paper, reversal of coronary heart disease. Fine. But if you look at it and what it's claiming, it says it may lead to regression of coronary atherosclerosis after 1 year. In fact, it's throughout the paper. Regression of coronary atherosclerosis.
Yeah, you can find
reversing, and you can also say, and just so someone says, hey, he's talking about reversal of coronary heart disease, not reversal of coronary artery disease. No, he's also saying, because some people have tried, I'm not going to say who, have tried to make the case that, oh, there's this distinction, which fine, they could be, but he's talking about this as well. If you look, these findings, quote, these findings support the feasibility of intensive lifestyle changes in delaying, stopping, or reversing the progression of coronary artery disease in ambulatory patients over prolonged periods. So he is talking about coronary artery disease, and if you look at atherosclerosis, and if he's talking about obstructive or non-obstructive, if you just look at throughout, it's just atherosclerosis continued to progress in the control group. Atherosclerosis could be stopped or reversed. Coronary atherosclerosis. Show the will most likely, okay, those who gain weight most likely show progression of coronary atherosclerosis. In fact, if you just type in reverse, regression of coronary atherosclerosis after 1 year. Okay, so he's talking about regression of coronary atherosclerosis. Just so no one tries to say that, oh, okay, he's talking about something that I'm not talking about. We're talking about the same thing. It's pretty clear.
Very clear.
Here is a publication in the Chicago Tribune saying Esselstyn said that he has seen a plant-based diet reverse plaque buildup and halt symptoms such as, so reverse plaque buildup. We're talking about the same thing, right? We're talking about reversal of plaque buildup. All right, so there's no ambiguity here. There's no way to say that they're talking about something proprietary. They may be talking about that as well, but regarding this claim that it is making, I am saying that this has not been shown. Okay. Now let's go through the syllogism. And let's screen share. Pull it up. All right, the best way to do this will probably be to download it, I guess. Do that. I couldn't. Okay, here we go. So, can you see this? Am I still screen sharing? Can you see this?
Yeah, I can see it.
Okay. All right. So, this is the formal syllogism called the Bilardo-Bitterman EASCVD epicardial atherosclerotic cardiovascular disease reversal syllogism. So, the central argument is as follows. Premise 1, if the only support shown for EASCVD reversal in humans from a plant-based diet are QCA without equal or greater than 0.4 millimeter criteria, MPI, and symptom/event outcome-based studies, then it is not the case that a plant-based diet has been shown to reverse EASCVD in humans. So that's just P implies not Q. Premise 2 is the only support shown for the EASCVD reversals in humans from plant-based diet are QCA without equal or greater to 0.4 millimeter criteria, MPI, and or symptom event outcome-based studies. That's just asserting P. I'll also include changes in ejection fraction will be subsumed under outcome-based studies. Same thing for anecdotes. And then conclusion, it just follows, therefore, it is not the case that plant-based diet has been shown to reverse EASCVD in humans. Premise 2 is their assumption for reductio, because that is the Ornish Esselstyn position. That is the only evidence that they have put forth for this. So it's there as an assumption for reductio. Premise 1, if you want to reject premise 1, there are supporting arguments. Supporting argument alpha for premise 1 is the following. If quantitative coronary angiography without equal or greater than 0.4 millimeter criteria has not been shown to correlate with change in plaque volume and myocardial perfusion imaging and or outcome-based studies on symptoms and or events under determined change in plaque, then if the only support shown for EASCVD reversal in humans from a plant-based diet are quantitative coronary angiography without equal or greater than 0.4 millimeter criteria, MPI and or symptom event outcome-based studies, then it is not the case that a plant-based diet has been shown to reverse EASCVD in humans. So it's just saying R and S implies if P, then not Q. Premise 2 is just asserting R and S. That's the same thing I read. It's the first half of premise 1. And conclusion is just P implies not Q. So notice how this conclusion is premise 1. So this is an argument for premise 1. Right. So it's a deductively valid argument. So in order to reject premise 1, you need to reject either premise 1 over here or premise 2 over here of the supporting argument for premise 1. What are the pathways? If you try to reject premise 1, that's hilarious because that's actually an analytic entailment. Premise 1 is just saying if you can't show a change in plaque, then you cannot show a reversal in plaque. Well, that's just analytically true because reversal is just a subset of change.
Yeah.
So that's just analytically the case. If you want to try to reject premise 2, then we have a supporting argument for premise 2. Here's the supporting argument for premise 2. Premise 1, if quantitative coronary angiography without equal or greater 0.4 millimeters minimum lumen diameter criteria has not been shown to correlate with change in plaque volume in humans, R. Premise 2, myocardial perfusion imaging and or outcome-based studies on symptoms and or events under determined change in plaque in humans, that's S. Conclusion, therefore, quantitative coronary angiography without equal or greater 0.4 millimeter criteria has not been shown to correlate with change in plaque volume in humans, and MPI and or outcome-based studies on symptoms and or events under determined change in plaque in humans. So that's just, it's an argument for R and S. That's not something very interesting here. It's just saying, here's argument, here's premise, here's R, here's S, therefore R and S. Well, to reject R and S, you have to reject either R or S. That makes sense. If you try to reject R, which is premise 1, that's just the data. The data shows no correlation unless you stratify by 0.4 millimeter criteria or greater. That's the data we already went over. If you try to reject premise 2, which is S, well, if you want to reject premise 2 and say it's not underdetermined, well, here's the list of all the competing hypotheses that do underdetermine it. Dilation, collateral formation, medication, plaque stabilization, demand. And just for comedy purposes, I'll include pomegranate juice because that's actually also now a rival hypothesis that underdetermines the conclusion. So the point is that there's no analysis that they have to show that it's more likely that we have reason to believe there's a regression of plaque rather than any combination of any of these other rival hypotheses. And if anyone thinks they have a counter argument to this, I'll stop the screen sharing now, and I'll be happy to take anyone, serious contenders only, on stream, because I do want to know that if I'm wrong, I do want to know that I'm wrong. And so I'm happy to go into your Discord server and take any contenders if they want to go on stream.
Do you want to do that now?
Yeah, we can do that now. Unless you have any questions about the central point of it. Oh, actually, you know what? Let me go through just the final thoughts. So here's the thing. My primary conclusion here, and what should be the conclusion, it's not just that dietary or lifestyle interventions has been shown to reverse atherosclerotic coronary artery disease, even though that's true, it hasn't been shown. But the real takeaway here should mainly be that reversal of atherosclerotic coronary artery disease isn't actually the important thing that we care about compared to things that actually matter, which is CVD events, mortality events, symptoms. At the end of the day, can you walk up a flight of stairs again? At the end of the day, are you going to be the victim of another heart attack? And are you going to go to the hospital again? Are you going to die from another heart attack? Those are the things that matter. And those are the things we actually do have data for a plant-based diet on. That's what we should be focusing on. Perhaps instead of reversal, we should be claiming things like beyond reversal. Maybe that would be a good slogan, beyond reversal. At least that way we're not making a false claim if we're talking about ASCVD. And that is conveying the right message, that what we're caring about is not just reversal of ASCVD, because what really matters is, are you going to die? Are you going to get another heart attack? Are you going to be able to walk up another flight of stairs? Not, did your absolute atheroma volume change by 0.1% or 2%?
Like,
that's not what matters.
Yeah, like it's conceivable that even with disease reversal, your risk of death could increase. So like, who cares?
Yeah.
Yeah.
At the end of the day, the real takeaway should be reversal is not the thing that matters. The thing that matters is what we should be focusing on.
Okay. Right. So I think that sums things up. Stupid Windows. I think that sums things up. Discord's being weird. I think that sums things up really well. So if you want to jump in the debate Discord,
sure.
Why don't we do that? So
right, in the waiting room?
Yeah, so there's the debate room. I think you can just join in. I would say just go in the debate room. Yeah. And so I left a link to the Discord in the description, and I also linked it in the chat. So if anyone wants to jump in, just join the waiting room, and then we'll send you in the debate room.
All right. And I'm coming through the stream and everything. The audio is fine.
Yep.
In this room. Okay. Cool.
Yeah, it's fine.
Oh, okay. This actually is something I should have addressed. Do we have any better techniques to measure plaque buildup that I'm aware of? Yes. So IVUS or OCT or CCTA. So those things can measure plaque volume. Intravascular ultrasound, optical coherence tomography, or CCTA. Those things, we do have techniques that actually can measure plaque volume. And again, just serious contenders only. If you really think, because here's the thing, at the end of the day, I will right now, if I'm wrong, I will right now say, hey, listen, I was wrong about this. But I have run this by experts. I don't see a refutation for this. I'm running it by everyone. I'm running it by the community at large. And if I'm wrong, I'll be happy to admit I'm wrong. So if anyone thinks that they have a hole in what I'm saying right now, please explain it to me, and I'll be happy to listen.
Yeah, I see some people in the chat right now saying that nobody's going to debate you. There's like no refutation. So yeah, like if nobody wants to debate and somebody just wants to come in and ask a question, that's fine. But we do want to see someone try to refute this, ideally. But if not, feel free to come into the waiting room and we'll have you come in and you can ask any questions you want. Someone get Gregor in here, kick his booty.
And by the way, listen, Dr. Gregor, if you're watching this, you're welcome to come on too. If anyone is watching this, you're welcome to come on.
Yeah, so
or we can have a private conversation. That's fine.
Yeah, so if you want to talk, just join the waiting room. I see there's a few people in the actual server, but yeah. Okay, so here we go. Stepmom. Okay, so you're muted. I think I have to... Do I have to unmute you? Let's see. Oh, wait. I moved myself. Let me... I think they should be able to just talk.
Someone had messaged me that Mike the Vegan had commented, I don't want to distract, but to answer the question, it is my current view that the flow work in conjunction with the angiograms and other metrics still makes reversal valid. So no, it doesn't. As we've thoroughly discussed, that either results in. So first of all, with regression of atherosclerotic coronary artery disease, it absolutely does not. Neither the measurements in myocardial perfusion nor the measurements in quantitative coronary angiography give us reason to believe that there was regression of plaque rather than progression. If you're talking about some other definition of heart disease reversal, then you have to be very clear about how you're doing that, such that you're not biting the bullet on a whole bunch of other things causing a reversal disease. But in any case, with respect to the claim that was made, which is atherosclerotic coronary artery disease, there's no reason, there's no evidence you can present to give me reason to believe it's more likely that there was regression in plaque rather than progression, or rather than neither. That just completely face plants. It doesn't work at all. All right.
All right, Stefan?
Hola.
Yeah, go ahead.
Oh, I just meant to join the Discord. I didn't mean to, say something. Sorry, I'm just here to listen.
Oh, okay. All
My
right.
bad.
Okay, no problem.
Well, thanks for stopping by.
Hola, Avi.
How do I kick him out of the thing? Yeah, how do I move him out?
Can you
And
drag
kick- oh,
him? Can you
stiff.
drag him?
Yeah, just kick. Never mind. Okay. So the Panman Joe. I'll unmute you. So what's going on? Your mic's muted right now, so. Can you hear us, Panman?
He was never much of a talker.
Okay. I'll give him one last second. So it looks like he wanted to ask a question. So whole food diet doesn't reverse erectile dysfunction?
I haven't been convinced of that. No.
Okay, so
I mean, it can prevent buildup of atherosclerosis in the arteries, in the microcirculation that can cause erectile dysfunction. But if you have erectile dysfunction of that nature, can it reverse it? I don't know. I don't have a view on that. I haven't seen evidence that it does. In the majority of cases, erectile dysfunctions, and especially in healthy men, the most common cause is actually just psychological. So I haven't seen evidence to convince myself of that.
all right, so we have Grizzly Gladiator here. What's going on?
What's up?
All right, so did you have any question or did you want to debate?
I think he just left.
Okay, that's weird.
I guess not.
All right. So it looks like no one else is interested in really hopping in. So did you want to just say a few final words on this?
Yeah. We here's the thing. Ultimately, I think it's better. So a couple things. So first thing I'll say is nothing that I have found is something that could not have been found by a non-vegan, carnivore, or whatnot. It's just a matter of time. Maybe they wouldn't have never found out, but I think they would have. The truth always comes out. And I think that we can do a better job if we, in the future going forward, if we ourselves check ourselves in the claims that we're making and if we're stretching the envelope of science. Because if we do that and we self-correct our community, then we give a lot less ammunition to carnists to use as cannon fodder against us. So that's the idea of this. The idea is we need to self-correct our community. We need to self-check the claims that we're doing. We need to stand for truth, and we need to check our biases. And ultimately, that's my goal here. The truth is the hill that I want to die on, and that's all this really is. Okay, and if I'm shown to be wrong, I'll move to the other hill, and that's fine. And I hope I am wrong.
Okay, so Juliet had a question. What, if anything, has been proven to reverse coronary artery disease?
Sure. So there is some evidence for PCSK9 inhibitors and statins that have been shown to have a weak a low magnitude decrease in atheroma volume. There is some evidence for that. Does all of that evidence come down to LDL lowering? We don't know. There are some pleiotropic effects of statins. Statins can decrease inflammation in the plaque itself independently of cholesterol lowering. Maybe that has a role. PCSK9 may not have that, but they do have a very pronounced decrease in cholesterol, particularly LDL cholesterol. So yes, it has been shown with those medications. Will it end up being shown for a diet? Maybe. I hope so. can we conclude that just because it's been shown with that, that it'll be shown with diet? No, we cannot.
Okay, so Jaga, he wants to talk, it looks like.
Oh, and just real quick, before, just for the other question, other things that are obviously going to do that are mechanically getting rid of the plaque in certain ways, like just rotor-rooting. Yeah. Anyway.
Yeah, basically, I just wanted to ask a quick question. Does all of this mean that there is basically no way to clear your arteries of plaque once you have it?
No, that's not what it means. It just means that it hasn't been shown that this specific intervention reverses the plaque.
Yeah, so diet. But you could do it mechanically.
Yeah,
diet and lifestyle. And even some medications have a very mild amount of reversal that has been shown.
Okay, but basically, should we still keep using the whole food plant-based diet in the future or not?
Yes, absolutely. We should. And well, let me just say, when I say whole foods is a heuristic. It's not a law. There are certain things that are totally fine that are processed, like heavily processed, like protein powder is processed. It's not a whole food, but I don't have a problem with protein powder. I think that's actually a good thing in terms of health for many people. So whole foods is a heuristic. It's not a law. Don't take it as a law. So I would just say, yeah, just a vegan, a healthy, well-balanced vegan diet.
Okay, that was all I just wanted to ask. Thank you very much.
All right, thanks. Okay, and we have Menags. Can you hear us?
Yeah, can you hear me?
Yeah, we can hear you loud and clear.
Yeah, so I just had a question. I agree that, event reduction, everything is what we care about, but what about claiming halting the progression? Is that something that's fair to say?
No, because of the same reason. So remember, if quantitative coronary angiography, if quantitative coronary angiography doesn't track with change in plaque volume, then we don't actually have a basis to say it halted the progression either in plaque volume. And same thing with the myocardial perfusion studies. The MPI studies under determined change of plaque, we actually don't know if the plaque progressed, regressed, or stayed the same. So we actually can't claim that it halted the progression.
Okay, thanks. Yeah, no, that makes sense.
Yeah. But again, just because we can't claim it didn't halt the progression, that it halted the progression, and we can't claim that it reversed it, doesn't mean this whole thing is not what even matters. That's what we need to focus on.
Yeah, I agree with that.
All right, so was that it?
Yeah, that was all I had.
All right, well, thanks for coming on. Okay, stop kicking people, disconnect them. Oh, shit, okay. I don't know.
Oh, yeah, you're kicking them from the server. You're kicking them from your server.
Sorry, I'm not, I don't know, Discord. Okay, it looks like that's pretty much it as far as, major questions go.
All right, cool. Well,
okay.
Listen,
here's
if there
one.
is...
Here's an interesting one. Didn't Dr. Bellardo say actual stenting reverses it, reopening the artery?
I'm not sure if she said that. I'd have to let her just... because I've actually spoke to Danielle, and she, if I recall correctly over the phone, she said that actually wouldn't be a reversal. But I don't know. I would have to look and see, and maybe she can clarify. But regardless, if you're asking me, I would not consider that reversal. I wouldn't consider that reversal of plaque. That the disease is there. You are circumventing the disease. You're finding a way to either smush it out of the way, or you can do a bypass and circumvent the disease. But the disease is there.
Right. Okay. Tetra asks, can you also get plaque buildup in brain arteries? So the arteries in your brain.
Yes, it is possible to get plaque buildup in your brain artery.
Yeah, and that's one of the reasons why risk factors for heart disease also associate with dementia. Okay, so that looks like it. That looks like it's basically it. So I think this was a pretty good stream. Check out Dr. Avi's channel. I'll leave it linked in the description after this stream is over. And yeah, if you ever want to do any more streams like this, Avi, anytime.
Yeah, for sure, absolutely. Yeah, and if anyone, like again, please, if anyone thinks they do have the refutation to my argument, I am more than happy to have a conversation. Stop by my Discord or the Ask Yourself Discord. Reach out to me. I'm more than happy to hear it. So if you do have a refutation, I'm always happy to change my mind.
Yeah, you can also reach him on Twitter as well, right?
Yeah, my Twitter, yeah.
Yeah, so anytime anybody wants to debate Avi on this topic, he'll take you up as long as you're serious about it.
For sure. All right, well, thanks for having me on, Richard.
Yeah, no problem. Okay, so take care. The stream will stay up, so if anybody wants to, look back and take a look at the research, all the research linked is also in your Discord.
Do we have
as well.
Someone who wants to debate? I think someone wants to debate, actually.
Okay. Oh, we do? Who?
You're saying this person, one live mic?
One live mic. Okay, he's not in the waiting room.
He's in your Discord saying, how do I do for it? He's typing in your Discord.
Oh, okay. You just have to join the waiting room.
Mm-hmm.
Okay, let's see. I think the waiting room holds 10 people, so he should be able to just join in.
I'm telling him to join the waiting room in voice chat. Will he show? I think he needs to learn how to use Discord first, unfortunately.
Okay, well, there's a few other people. How about I drag in Barmy? So Barmy, oh, okay. He's back in the waiting room somehow.
Okay, there we go.
So,
all right, it looks like this person isn't coming to debate, I guess.
Okay, okay. Well,
is there
anyway.
Another one? All right, that's fine.
Let's see. I'll try to drag in Barmy. Okay, do you hear us?
I can hear you. Can you hear me?
Yeah, we can hear you.
Yes, I can hear you.
Cool. Thank you. So, Avi, since you just said that there are more practical issues that we should be focused on, that they matter more, like walking up a staircase, being able to walk again, or, just getting, regaining a more functional life through nutrition and proper blood flow. Do you think it may be worth to think about a new definition of heart disease reversal? Something more practical?
I do. I actually mentioned it. I think a good way of phrasing this, and you can take it or leave it, you don't have to take my phrasing, but I think a good way of phrasing this will be beyond reversal. Yeah, because that shows that, first of all, it doesn't make a false claim with respect to atherosclerotic coronary artery disease. And it also it has a good message that you're going beyond reversal. And it's true, because the things that really matter are not reversal.
Cool. All right. That's great. Thank you. Thank you. Please, vegan gains, don't kick me.
Yeah, sure. I'm going to disconnect. All right. There we go. So Jaga also wanted to come on. Jaga, can you hear us?
Yeah, sure. I just forgot to ask something the last time I was here. Just one more thing. What is your position on salt?
I don't see what the relevance to that is, but I do think there's, in the, if you look at the meta-analyses of, I believe it was cohort-based data, there's kind of a U-shaped mortality curve with salt intake. If you have to, surprise, surprise, if you get too much of it, it can be bad. If you get too little of it, it can be bad. And that U-shaped curve can shift based on what your conditions are. If you have congestive heart failure, you may require less of that. That U-shaped curve can move to the left of the curve. So there are recommendations for like a range of intakes, but regardless of that, I don't see what the respectfully, I don't see what the relevance is to this topic specifically. Did you have a question about this specific topic of reversal, or did you just want to talk about salt?
I thought it was connected because usually the people who propagate a whole food plant-based diet recommend taking salt, sugar, and oil out of it. So I just wanted to ask
Okay. Yeah. Okay. So I don't think there's any, to answer your question, I don't think there's any reason to eliminate all oil from your diet. I'm just not convinced of that. When you do an apples to apples comparison, you can see that diets that include oil and even margarine, plant-based margarines, they have similar event rates as the Esselstyn study when you do an apples to apples comparison with it, not when you do a dishonest comparison. And I don't see why you would have to eliminate all salt from your diet either. So no, I don't take that position.
Okay, thank you very much.
All right, well, thanks for coming on. Take care. Okay, let's have the Panman Joe come on. All right, can you hear us? Your mic is muted. Can you hear us at all? We'll give you just like 30 seconds to figure it out. So if anyone has a question in the chat here, just join the waiting room. Okay. Let's have ET Dominance come on. All right, can you hear us?
Yeah, what's up, man?
All right, so what was your question?
Yeah, I was just wondering. No.
I'm having a little trouble hearing you. Hello?
Are you like watching the stream at the same time without headphones?
Alright, so what was your question?
Okay, I'm just going
Sounds
to
like he's
disconnect
watching the
him.
stream, yeah.
Yeah. Okay, so
Oh, his question
Sean.
was, is fat from whole food sources bad? No, I don't think fat in and of itself is bad. Whether it be from whole food sources or from even added oils necessarily. It all depends on dosages. Okay, Sean, what's going on?
Yeah, so I have two questions, if that's okay.
Yeah, it's fine.
All right. The first one is, I came in late, so sorry, but the first one is, what do the angiograms in Esselstyn's paper then mean if it doesn't show reversal? That's my first question. And then second question is dietary cholesterol still an issue?
Okay, so the answer to the first question is the angiograms, what they showed in the Esselstyn study is they found a statistically significant difference in percent stenosis. And what that means, it could mean a whole number of different things. There's a lot of different ways you can get a three-dimensional lumen, your blood volume in three-dimensional space can have an improvement in stenosis. It does not show a statistically significant increase in minimal luminal diameter. That can happen for a whole host of different reasons. You can have a decrease. You can have a dilation of just the stenotic segment of the artery. You can have a regression of some amount of plaque. You can have you can have a different angle that you're looking at the artery at. There's a whole bunch of different things, but ultimately the point being is that it doesn't give us a reason to. What it doesn't show is that it doesn't show that we have a reason to believe that plaque had regressed rather than progressed, rather than neither progressed or regressed, as borne out in the data.
Okay.
And the second question was about dietary cholesterol.
Oh yeah, sorry. And the second question is dietary cholesterol. Yeah, it always was an issue. It's not something that ever changed. So dietary cholesterol increases your serum LDL. There's a relationship. If you look up Mackey's meta regression analysis, there absolutely is a relationship between dietary cholesterol and LDL. And so I don't see why it wouldn't matter. Now, does it matter as much as other things like saturated fat or if you're going to be obese or not? Probably not. Does it not matter at all? No, it matters to some degree.
Okay, and you would probably would you say the same thing for like refined carbohydrates?
So added sugars, if you're talking about added sugars, the recommendation is to limit them to 10% of your calories or lower. Some people, there are some, if you're talking about certain dental caries and based on certain data, to limit them to 5% of calories or lower for added sugars. But I'm not talking about carbohydrates in general there, obviously.
Yeah. Okay, that's all I wanted to ask. Please don't kick me, Vegan Dance.
Yeah, sure. I've been disconnecting people.
All right,
we'll take care.
Thanks.
Okay, so Vegan Fire also asks, can we say we can achieve diabetes reversal? So like type 2 diabetes.
So here's the thing. It depends on what you mean. When you say reversal, do you mean you're talking about not having the diabetes anymore? Because there are issues with that they're involving things like De Morgan's law based on the criteria of diagnosing diabetes, or do you mean that we can improve glucose control? If you're saying we can improve glucose control, yes, I agree that's been shown. If you're saying we can reverse diabetes to the point where you no longer have diabetes, I'm not aware of data showing that, because there's a complicated reason why that we may not have time to get into. It has to do with how diabetes is diagnosed based on disjunctions, and then like in order to say you don't have it, you would have to negate the conjunction of those 4 criteria, and it's very hard to do that. But if you're just asking reverse diabetes and all you mean by that is to improve the blood sugar control or hemoglobin A1C or things like that, yeah, sure.
And to the point where you could actually go off of medications?
Yeah, to the point where it may be possible to go off of medications for some people.
All right.
Although I would be very cautious of doing that without any physician guidance.
Sure.
And I would probably, before I make that claim, I'd probably actually have to look more in depth on that. But that I do like, if you have diabetes and your blood sugar levels are tanking because you have made dietary improvement so much, then yeah, you may have to go off your diabetic medications, and that's fine.
Okay, so ET dominance is back.
Yeah, what's up, man? Can you hear me?
Yeah, we can hear you.
Yeah. This is a question for Avi. Avi, do you think Dr. Greger is really just dishonest? What is your opinion of him?
I think he's an ethical vegan, and I think he has his heart in the right place. But I do think he stretches the envelope of science, and I think it's very unfortunate that he does. He may think that doing that, I don't know. It's hard to make a claim about what his mind state is. There are certain things that he's done that make me very suspicious, but I can't fully make a claim one way or other, whether it's just stretching the envelope of science, run-of-the-mill ideology, or whether it's actual disingenuousness. Part of me thinks he has to know that he's stretching the envelope, but hey, I can't prove it. So
yeah, just like his bodybuilder study, that was just stupid.
Well, there are a lot of issues with the things on nutrition facts. But
yeah.
Anyway.
Also, what would you recommend? Would you recommend keeping fat from whole food sources like nuts and seeds under carbohydrates?
No, I'm not necessarily. I think there are people who have had excellent results on vegan keto. Even like it varies. It all depends on you. You can have majority of your calories from fat. It's not saturated fat, obviously, but
yeah.
If you're doing PUFAs, MUFAs, I don't actually see a problem with that.
Polyunsaturated fats. Yeah.
Yep.
Yeah. Also, when is the debate with vegan gains on abortion?
Oh, that's a good one. We have to schedule that. I can't comment on the debate about reversal at this time, but that's been taking up my time. But yes, we definitely do have to schedule that debate on abortion.
Wait, so you're pro-life, right?
Mostly pro-life, not pro-life to the point of like Ben Shapiro pro-life that we shouldn't kill it would be murder to kill a zygote. But I would say that yeah, but I would say that I would say actually, if you want to talk technically about it, pro-lifers would disagree with me and pro-choicers would disagree with me on a lot of things.
Have you ever
yeah, go ahead.
Have you ever looked into overpopulation?
Sure.
And the overpopulation studies?
Yeah, I'm aware of the issues of overpopulation. I'm there, but is there where is this going?
Do you think can you refute the claim that abortion is we need abortion to control the population?
I mean, name the trait between that and killing babies. I mean, what if someone told you that we need to kill babies to control overpopulation? Would you accept that?
Yeah. I mean, so it's not even a baby though; it's just a lump of cells.
Wait a minute. I'm not talking about. That's fine. I'm talking about post-sentience.
You're talking about, okay, post-sentience.
All right. This is getting like way off topic. So maybe if you like, maybe in the Avi debate, we could have a discussion after that once we set that up. But this is way
Oh,
off
shit.
topic.
I'm sorry, man.
Yeah, no problem.
That's all I had, because I was just,
All
I debate idiots on abortion. Dr.
Sure.
Avi.
Yeah,
He's an
maybe you
idiot.
can debate him on his Discord or Ask Yourself's Discord, or maybe we can set up a discussion like when I debate him afterwards, something like that. But yeah, this isn't the place to do it right now. But
Yeah.
thanks for coming on.
Sure.
Okay, Wesson asks, does nerve function like the small fiber nerves of the arteries contribute to atherosclerosis?
I'm not sure.
Okay. All right, I think that's basically it for all the big questions. So thanks for coming on, Avi. Maybe we can do something like this again. Anytime you want
Yeah,
to kind
for sure.
of
It's
do
a
a big
pleasure.
discussion on the science. And again, the video will be up if in case any of you missed any of it. The whole stream will be up after the stream's over. So yeah, I'm just going, and oh yeah, make sure you subscribe to Avi's channel. It's is it just Avi or is it Dr. Avi?
It's youtube.com/AviMD.
Okay, there you go. Okay, and I'll link it in the description afterwards as well. Okay, so I'll just end the stream now.